The esophagus is a muscular tube that starts as the continuation of the pharynx and ends as the cardia of the stomach. When the head is in a normal anatomic position, the transition from pharynx to esophagus occurs at the lower border of the sixth cervical vertebra. Topographically, this corresponds to the cricoid cartilage anteriorly and the palpable transverse process of the sixth cervical vertebra laterally. The esophagus is firmly attached at its upper end to the cricoid cartilage and at its lower end to the diaphragm. During swallowing, the proximal points of fixation move craniad the distance of one cervical vertebral body. The esophagus lies in the midline, with a deviation to the left in the lower portion of the neck and upper portion of the thorax, and returns to the midline in the mid portion of the thorax near the bifurcation of the trachea. In the lower portion of the thorax, the esophagus again deviates to the left and anteriorly to pass through the diaphragmatic hiatus. Key points. One benign esophageal disease is common and is best evaluated with thorough physiologic testing and anatomic testing. 2. Gastroesophageal reflux disease is the most common disease of the gastrointestinal tract for which patients seek medical therapy. When GERD symptoms are troublesome despite adequately dosed PPI, surgical correction may be indicated. Barrett's esophagus is the transformation of the distal esophageal epithelium from squamous to a specialized columnar epithelium capable of further neoplastic progression. The detection of Barrett's esophagus on endoscopy and biopsy. 3. Normal area increases the future risk of cancer by greater than 40 times compared to individuals without Barrett's esophagus. 4. Giant hiatal hernia, otherwise known as periesophageal hernia, should be repaired when symptomatic or associated with iron deficiency anemia. Laparoscopic hiatal hernia repair with fundoplication is the most common approach to repair. 5. Achalasia is the most common primary esophageal motor disorder. It is characterized by an absence of peristalsis and a hypertensive, non-relaxing lower esophageal sphincter. It is best treated with laparoscopic Heller myotomy and partial fundoplication. 6. Most esophageal cancer presents with dysphagia, at which time it has invaded the muscularis of the esophagus and is often associated with lymph node metastases. The preferred treatment at this stage is multimodality therapy. 3. Normal areas of esophageal narrowing are evident on the barium esophagram or during esophagoscopy. The uppermost narrowing is located at the entrance into the esophagus and is caused by the cricopharyngeal muscle. Its luminal diameter is 1.5 centimeters, and it is the narrowest point of the esophagus. The middle narrowing is due to an indentation of the anterior and left lateral esophageal wall caused by the crossing of the left main stem bronchus and aortic arch. The luminal diameter at this point is 1.6 centimeters. The lowermost narrowing is at the hiatus of the diaphragm and is caused by the gastroesophageal sphincter mechanism. The luminal diameter at this point varies somewhat, increases the future risk of cancer depending on the distension of the esophagus by the passage of food, but has been measured at 1.6 to 1.9 centimeters. These normal constrictions tend to hold up swallowed foreign objects, and the overlying mucosa is subject to injury by swallowed corrosive liquids due to their slow passage through these areas. Figure 25-3 shows the average distance in centimeters measured during endoscopic examination between the incisor teeth and the cricopharyngeus, aortic arch, and cardia of the stomach. Manometrically, the length of the esophagus between the lower anatomy. 1012 tore above and the inner circular muscle fibers of the esophagus below. Some investigators believe that the cricopharyngeus is part of the inferior constrictor. That is, that the inferior constrictor has two parts, an upper or retrothyroid portion having diagonal fibers, and a lower or retrocricoid portion having transverse fibers. Keith in 1910 showed that these two parts of the same muscle serve totally different functions. The retrocricoid portion serves as the upper sphincter of the esophagus and relaxes when the retrothyroid portion contracts to force the swallowed bolus from the pharynx into the esophagus. The cervical portion of the esophagus is approximately 5 centimeters long and descends between the trachea and the vertebral column. From the level of the sixth cervical vertebra to the level of the interspace between the first and second thoracic vertebrae posteriorly, or the level of the suprasternal notch anteriorly. The recurrent laryngeal nerves lie in the right and left grooves between the trachea and the esophagus. The left recurrent nerve lies somewhat closer to the esophagus than the right, owing to the slight deviation of the esophagus to the left, and the more lateral course of the right recurrent nerve around the right subclavian artery. Laterally, on the left and right sides of the cervical esophagus are the carotid sheaths and the lobes of the thyroid gland. The thoracic portion of the esophagus is approximately 20 centimeters long. It starts at the thoracic inlet. In the upper portion of the thorax, it is in intimate relationship with the posterior wall of the trachea and the prevertebral fascia. Just above the tracheal bifurcation, the esophagus passes to the right of the aorta. This anatomic positioning can cause a notch indentation in its left lateral wall on a barium swallow radiogram. Immediately below this notch, the esophagus crosses both the bifurcation of the trachea and the left main stem bronchus, owing to the slight deviation of the terminal portion of the trachea to the right by the aorta. From there down, the esophagus passes over the posterior surface of the subcarinal lymph nodes and then descends over the pericardium of the left atrium to reach the diaphragmatic hiatus. From the bifurcation of the trachea downward, both the vagal nerves and the esophageal nerve plexus lie on the muscular wall of the esophagus. Dorsally, the thoracic esophagus follows the curvature of the spine and remains in close contact with the vertebral bodies. From the 8th thoracic vertebra downward, the esophagus moves vertically away from the spine to pass through the hiatus of the diaphragm. The thoracic duct passes through the hiatus of the diaphragm on the anterior surface of the vertebral column behind the aorta and under the right crus. In the thorax, the thoracic duct lies dorsal to the esophagus between the azygos vein on the right and the descending thoracic aorta on the left. The abdominal portion of the esophagus is approximately 2 centimeters long and includes a portion of the lower esophageal sphincter. It starts as the esophagus passes through the diaphragmatic hiatus and is surrounded by the phrenoesophageal membrane, a fibroelastic ligament arising from the subdiaphragmatic fascia as a continuation of the transversalis fascia lining the abdomen. The upper leaf of the membrane attaches itself in a circumferential fashion around the esophagus, about 2 cm above the level of the hiatus. These fibers blend in with the elastic containing adventitia of the abdominal esophagus and the cardia of the stomach. This portion of the esophagus is subjected to the positive pressure environment of the abdomen. The musculature of the esophagus can be divided into an outer longitudinal and an inner circular layer. The upper 2 to 6 centimeters of the esophagus contains only striated muscle fibers. From then on, smooth muscle fibers gradually become more abundant. Most clinically significant esophageal motility disorders involve only the smooth muscle in the lower 2/3 of the esophagus. When a long surgical esophageal myotomy is indicated, the incision needs to extend only this distance. The longitudinal muscle fibers originate from a cricosophageal tendon arising from the dorsal upper edge of the anteriorly located cricoid cartilage. The two bundles of muscle diverge and meet in the midline on the posterior wall of the esophagus about 3 centimeters below the cricoid. From this point on, the entire circumference of the esophagus is, figure 25-5, a cross-section of the thorax at the level of the tracheal bifurcation, covered by a layer of longitudinal muscle fibers. This configuration of the longitudinal muscle fibers around the most proximal part of the esophagus leaves a V-shaped area in the posterior wall covered only with circular muscle fibers. Contraction of the longitudinal muscle fibers shortens the esophagus. The circular muscle layer of the esophagus is thicker than the outer longitudinal layer. In situ, the geometry of the circular muscle is helical and makes the peristalsis of the esophagus assume a worm-like drive, as opposed to segmental and sequential squeezing. As a consequence, severe motor abnormalities of the esophagus assume a corkscrew-like pattern on the barium swallow radiogram. The cervical portion of the esophagus receives its main blood supply from the inferior thyroid artery. The thoracic portion receives its blood supply from the bronchial arteries, with 75% of individuals having 1 right-sided and 2 left-sided branches. 2 esophageal branches arise directly from the aorta. The abdominal portion of the esophagus receives its blood supply from the ascending branch of the left gastric artery and from inferior phrenic arteries. On entering the wall of the esophagus, the arteries assume a T-shaped division tube. Figure 25-7, attachments and structure of the phrenoesophageal form a longitudinal plexus giving rise to an intramural vascular network in the muscular and submucosal layers. As a consequence, the esophagus can be mobilized from the stomach to the level of the aortic arch without fear of devascularization and ischemic necrosis. Caution, however, should be exercised as to the extent of esophageal mobilization in patients who have had a previous thyroidectomy with ligation of the inferior thyroid arteries proximal to the origin of the esophageal branches. Blood from the capillaries of the esophagus flows into a submucosal venous plexus and then into a periesophageal. Figure 25-8, venous plexus from which the esophageal veins originate. In the cervical region, the esophageal veins empty into the inferior thyroid vein. In the thoracic region, they empty into the bronchial azygos or hemiazygos veins. And in the abdominal region, they empty into the coronary vein. The submucosal venous networks of the esophagus and stomach are in continuity with each other and in patients with portal venous obstruction. This communication functions as a collateral pathway for portal blood to enter the superior vena cava via the azygos vein. The parasympathetic innervation of the pharynx and esophagus is provided mainly by the vagus nerves. The constrictor muscles of the pharynx receive branches from the pharyngeal plexus, which is on the posterior lateral surface of the middle constrictor muscle, and is formed by pharyngeal branches of the vagus nerves with a small contribution from cranial nerves 9th and G. The cricopharyngeal sphincter and the cervical portion of the esophagus receive branches from both recurrent laryngeal nerves, which originate from the vagus nerves. The right recurrent nerve at the lower margin of the subclavian artery and the left at the lower margin of the aortic arch. They are slung dorsally around these vessels and ascend in the groove between the esophagus and trachea, giving branches to each. Damage to these nerves interferes not only with the function of the vocal cords, but also with the function of the cricopharyngeal sphincter and the motility of the cervical esophagus, predisposing the individual to pulmonary aspiration on swallowing. Afferent visceral sensory pain fibers from the esophagus end without synapse in the first 4 segments of the thoracic spinal cord, using a combination of sympathetic and vagal pathways. These pathways are also occupied by afferent visceral sensory fibers from the heart. Hence, both organs have similar symptomatology. The lymphatics located in the submucosa of the esophagus are so dense and interconnected that they constitute a single, figure 25-9, venous drainage of the esophagus. Innervation of the esophagus, plexus. There are more lymph vessels than blood capillaries in the submucosa. Lymph flow in the submucosal plexus runs in a longitudinal direction, and on injection of a contrast medium, the longitudinal spread is seen to be about 6 times that of the transverse spread. In the upper 2/3 of the esophagus, the lymphatic flow is mostly cephalad, and in the lower third, caudad. In the thoracic portion of the esophagus, figure 25-11, lymphatic drainage of the esophagus, 475 to 531. The submucosal lymph plexus extends over a long distance in a longitudinal direction before penetrating the muscle layer to enter lymph vessels in the adventitia. As a consequence of this non-segmental lymph drainage, a primary tumor can extend for a considerable length superiorly or inferiorly in the submucosal plexus. Consequently, free tumor cells can follow the submucosal lymphatic plexus in either direction for a long distance before they pass through the muscularis and on into the regional LNS. The cervical esophagus has more direct segmental lymph drainage into the regional nodes, and as a result, lesions in this portion of the esophagus have less submucosal extension and a more regionalized lymphatic spread. The effort lymphatics from the cervical esophagus drain into the paratracheal and deep cervical LNS, and those from the upper thoracic esophagus empty mainly into the paratracheal LNS. Efferent lymphatics from the lower thoracic esophagus drain into the subcarinal nodes and nodes in. The first diagnostic test in patients with suspected esophageal disease is usually upper gastrointestinal endoscopy. This allows assessment and biopsy of the mucosa of the stomach and the esophagus, as well as the diagnosis and assessment of obstructing lesions in the upper gastrointestinal tract. In any patient complaining of dysphagia, esophagoscopy is indicated, even in the face of a normal radiographic study. For the initial endoscopic assessment, the flexible fiber optic esophagoscope is the instrument of choice because of its technical ease, patient acceptance, and the ability to simultaneously assess the stomach and duodenum. Rigid endoscopy is now only rarely required, mainly for the disimpaction of difficult foreign bodies impacted in the esophagus, and few individuals now have the skill set and experience to use this equipment. When GERD is the suspected diagnosis, particular attention should be paid to detecting the presence of esophagitis and Barrett's columnar lined esophagus. When endoscopic esophagitis is seen, severity and the length of esophagitis involved are recorded. Whilst many different grading systems have been proposed, the commonest system now in use is the Los Angeles grading system. In this system, mild esophagitis is classified LA grade A or B, 1 or more erosions limited to the mucosal fold, and either less than or greater than 5 millimeters in longitudinal extent, respectively. More severe esophagitis is classified LA grade C or D. In grade C, erosions extend over the mucosal folds, but over less than 3/4 of the esophageal circumference. In grade D, confluent erosions extend across more than 3/4 of the esophageal circumference. In addition to these grades, more severe damage can lead to the formation of a stricture. A stricture severity can be assessed by the ease of passing a standard endoscope. When a stricture is observed, the severity of the esophagitis above it should be recorded. The absence of esophagitis above a stricture suggests the possibility of a chemical-induced injury or a neoplasm as a cause. The latter should always be considered and is ruled out only by evaluation of a tissue biopsy of adequate size. It should be remembered that gastroesophageal reflux is not always associated with visible mucosal abnormalities, and patients can experience significant reflux symptoms despite an apparently normal endoscopy examination. Barrett's esophagus is a condition in which the tubular esophagus is lined with columnar epithelium, as opposed to the normal squamous epithelium. Histologically, it appears as intestinal metaplasia. It is suspected at endoscopy when there is difficulty in visualizing the squamocolumnar junction at its normal location, and by the appearance of a redder, salmon-colored mucosa in the lower esophagus, with a clearly visible line of demarcation at the top of the Barrett's esophagus segment. Its presence is confirmed by biopsy. Multiple biopsy specimens should be taken in a cephalad direction to confirm the presence of instant massage and to evaluate the Barrett's epithelium for dysplastic changes. B is susceptible to ulceration, bleeding, stricture formation, and most important, malignant degeneration. The earliest sign of the latter is high-grade dysplasia or intramucosal adenocarcinoma. These dysplastic changes have a patchy distribution, so a minimum of 4 biopsy samples spaced 2 centimeters apart should be taken from the Barrett's line portion of the esophagus. Changes seen in one biopsy are significant. Nishimaki has determined that the tumors occur in an area of specialized columnar epithelium near the squamocolumnar junction in 85% of patients, and within 2 centimeters of the squamocolumnar junction in virtually all patients. Particular attention should be focused on this area in patients suspected of harboring a carcinoma. Abnormalities of the gastroesophageal flap valve can be visualized by retroflexion of the endoscope. Hill has graded the appearance of the gastroesophageal valve from I to I4 according to the degree of unfolding or deterioration of the normal valve architecture. The appearance of the valve correlates with the presence of increased esophageal acid exposure, occurring predominantly in patients with grade 3 and IV valves. A hiatal hernia is endoscopic. GERD was not recognized as a significant clinical problem until the mid-1930s and was not identified as a precipitating cause for esophagitis until after World War II. In the early 21st century, it has grown to be a very common problem and now accounts for a majority of esophageal pathology. It is recognized as a chronic disease, and when medical therapy is required, it is often lifelong treatment. Recent efforts at the development of various endoscopic anterior flux interventions, although innovative, have not been successful in consistently controlling gastroesophageal reflux. Anterior flux surgery is an effective and relationship between hiatal hernia and gastroesophageal reflux disease. As the collar sling musculature and clasp fibers become attenuated with repeated gastric distension, the esophagogastric junction begins to assume an upside-down funnel appearance with progressive opening of the acute angle of his. This in turn may result in attenuation and stretching of the phrenosophageal ligament, with subsequent enlargement of the hiatal opening and axial herniation. There is a high degree of correlation between reflux threshold and the degree of hiatal herniation. Summary. It is believed that GERD has its origins within the stomach. Distension of the fundus occurs because of overeating and delayed gastric emptying secondary to a high-fat diet. The resultant distension causes unrolling of the sphincter by the expanding fundus, and this subsequently exposes the squamous epithelium in the region of the distal gastric juice. Repeated exposure results in inflammation and the development of columnar epithelium at the cardia. This is the initial step of the development of carditis and explains why in early selection of patients for surgery, studies of the natural history of GERD indicate that most patients have a relatively benign form of the disease that is responsive to lifestyle changes and dietary and medical therapy and do not need surgical treatment. Approximately 25% to 50% of the patients with GERD have persistent or progressive disease, and it is this patient population that is best suited to surgical therapy. In the past, the presence of esophagitis and a structurally defective LES were the primary indications for surgical treatment, and many internists and surgeons were reluctant to recommend operative procedures in their absence. However, one should not be deterred from considering anti-reflux surgery in a symptomatic patient with or without esophagitis or a defective sphincter, provided the disease process has been objectively documented by 24-hour pH monitoring. This is particularly true in patients who have become dependent upon therapy with PPIs or require increasing doses to control their symptoms. It is important to note that a good response to medical therapy in this group of patients predicts an excellent outcome following anti-reflux surgery. Objectively proven gastroesophageal reflux disease and typical symptoms of gastroesophageal reflux disease despite adequate medical management, or a younger patient unwilling to take lifelong medication. In addition, a structurally defective S can also predict which patients are more likely to fail with medical therapy. Patients with normal sphincter pressures tend to remain well controlled with medical therapy, whereas patients with a structurally defective LES may not respond as well to medical therapy and often develop recurrent symptoms within 2 years of beginning therapy. Such patients should be considered for an anti-reflux operation, regardless of the presence or absence of endoscopic esophagitis. In general, the key indications for anti-reflux surgery are young patients with documented reflux disease with or without a defective LES are also excellent candidates for anti-reflux surgery. They usually will require long-term medical therapy for control of their symptoms, and some will go on to develop complications of the disease. An analysis of the cost of therapy based on data from the Veterans Administration Cooperative Trial indicates that surgery has a cost advantage over medical therapy in patients less than 49 years of age. Severe endoscopic esophagitis in a symptomatic patient with a structurally defective LES is also an indication for early surgical therapy. These patients are prone to breakthrough of their symptoms while receiving medical. The primary goal of anti-reflux surgery is to safely create a new anti-reflux valve at the gastroesophageal junction, while preserving the patient's ability to swallow normally and to belch to relieve gaseous distension. Regardless of the choice of the procedure, this goal can be achieved if attention is paid to some basic principles when reconstructing the anti-reflux mechanism. First, the operation should create a flap valve, which prevents regurgitation of gastric contents into the esophagus. This will result in an increase in the pressure of the distal esophageal sphincter region. Following a Nissen fundoplication, the expected increase is to a level twice the resting gastric pressure. The extent of the pressure rise is often less following a partial fundoplication, although with all types of fundoplication, the length of the reconstructed valve should be at least 3 centimeters. This not only augments sphincter characteristics in patients in whom they are reduced before surgery, but also prevents unfolding of a normal sphincter in response to gastric distension. Preoperative and postoperative esophageal manometry measurements have shown that the resting sphincter pressure and the overall sphincter length can be surgically augmented over preoperative values, and that the change in the former is a function of the degree of gastric wrap around the esophagus. However, the aim of any fundoplication is to create a loose wrap and to maintain the position of the gastric fundus close to the distal intra-abdominal esophagus in a flap valve arrangement. The efficacy of this relies on the close relationship between the fundus and the esophagus, not the tightness of the wrap. Second, the operation should place an adequate length of the distal esophageal sphincter in the positive pressure. Figure, a graphic illustration of the shortening of the lower esophageal sphincter. Environment of the abdomen by a method that ensures its response to changes in intra-abdominal pressure. The permanent restoration of 2 or more cm of abdominal esophagus ensures the preservation of the relationship between the fundus and the esophagus. All of the popular anti-reflux procedures increase the length of the sphincter exposed to abdominal pressure by an average of at least 1 centimeter. Third, the operation should allow the reconstructed cardia to relax on deglutition. In normal swallowing, a vagally mediated relaxation of the distal esophageal sphincter and the gastric fundus occurs. The relaxation lasts for approximately 10 seconds and is followed by a rapid recovery to the former tonicity. To ensure relaxation of the sphincter, 3 factors are important. Only the fundus of the stomach should be used to buttress the sphincter. Nissen fundoplication. The most common anti-reflux procedure is the Nissen fundoplication. In the past, this procedure has been performed through an open abdominal or a chest incision, but with the development of laparoscopic approaches, primary anti-reflux surgery is now routinely undertaken using the laparoscope. Rudolf Nissen described this procedure as a 360-degree fundoplication around the lower esophagus for a distance of 4 to 5 centimeters, without division of the short gastric blood vessels. Although this provided good control of reflux, it was associated with a number of side effects that have encouraged modifications of the procedure as originally described. These include using only the gastric fundus to envelop the esophagus in a fashion analogous to a Witzel jejunostomy, sizing the fundoplication with a large bougie, limiting the length of the fundoplication to 1 to 2 centimeters, and dividing the short gastric vessels. The essential elements necessary for the performance of a transabdominal fundoplication are common to both the laparoscopic and open procedures and include the following: hiatal dissection and preservation of both vagi along their entire length, circumferential esophageal mobilization. 3. Hiatal closure, usually posterior to the esophagus. 4. Creation of a short and floppy fundoplication over an esophageal dilator. In addition, many surgeons also routinely divide the short gastric blood vessels, although this step is not universally applied, and the results of several randomized trials have failed to show that this step yields any benefit. The laparoscopic approach to fundoplication has now replaced the open abdominal Nissen fundoplication as the procedure of choice. 5 ports are usually used, and dissection is begun by incising the gastrohepatic omentum above and below the hepatic branch of the anterior vagus nerve, which is usually preserved. The circumference of the diaphragmatic, figure 25 to 34, patient position and introcar placement for laparoscopic anti-reflux surgery. The patient is placed with the head elevated approximately 30 degrees in the modified lithotomy position. The surgeon stands between the patient's legs, and the procedure is completed using 5 abdominal access ports. Hiatus is dissected, and the esophagus is mobilized by careful dissection of the anterior and posterior soft tissues within the hiatus. The esophagus is held anterior and to the left, and the hiatal pillars are approximated with interrupted non-absorbable sutures starting posteriorly and working anteriorly. A tension-free fundoplication should be constructed. This can usually be achieved either with or without division of the short gastric blood vessels according to surgeon preference. If the vessels are divided, the upper 1/3 of the greater curvature is mobilized by sequentially dissecting and dividing these vessels, commencing distally and working proximally. Following complete fundal mobilization, the posterior wall of the fundus is brought behind the esophagus to the right side, and the anterior wall of the fundus is brought anterior to the esophagus. The fundic lips are manipulated to allow the fundus to envelop the esophagus without twisting. A 50 to 60 Fahrenheit bougie is passed to properly size the fundoplication, and it is sutured using non-absorbable sutures. Some surgeons use a single U-stitch of 2 to 0 polypropylene buttress with felt pledgets, and others use 2 to 4 interrupted sutures. Posterior partial fundoplication. Partial fundoplications were developed as an alternative to the Nissen procedure in an attempt to minimize the risk of post-fundoplication side effects such as dysphagia, inability to belch, and flatulence. The commonest approach has been a posterior partial or two-pet fundoplication. Some surgeons use this type of procedure for all patients presenting for anti-reflux surgery, whereas others apply a tailored approach in which a partial fundoplication is constructed in patients with impaired esophageal motility, in which the propulsive force of the esophagus is thought to be insufficient to overcome the outflow. Obstruction of a complete fundoplication. The two-pet posterior partial fundoplication consists of a 270-degree gastric fundoplication around the distal. Eosinophilic esophagitis was first described in 1977, but it has become well known only in the last 2 decades. The condition is characterized by a constellation of symptoms, endoscopic and radiologic findings, and distinctive pathology. The etiology of eosinophilic esophagitis is not entirely known, but its similarities immunologically to asthma suggest that it is a form of allergic esophagitis. Symptoms. The presentation of eosinophilic esophagitis is chest pain and dysphagia. Dysphagia may occur with liquids or solids, but solid food dysphagia is most common. Because dysphagia and chest pain are characteristic of GERD, EE is often confused with GERD. However, EE does not respond to proton pump inhibitors. The evaluation of the patient with EE and dysphagia and chest pain with esophagram and endoscopy usually reveals the diagnosis. Signs. A barium swallow should be the first test obtained in the patient with dysphagia. EE has a characteristic finding often called the ringed esophagus or the feline esophagus, as the esophageal rings are felt to look like the stripes on a house cat. The endoscopic appearance of EE is also characteristic and also appears as a series of rings. Pathology. Endoscopic biopsy specimens should be taken when eosinophilic esophagus is suspected. To make the diagnosis of EE, the pathologist should see a minimum of 15 eosinophils per high-powered field, usually at the base of the epithelium. Treatment. The treatment of EE is largely symptomatic and includes testing for food allergies and elimination of identified items from the diet. Second-line therapy includes inhaled or ingested corticosteroids, as would be used to treat asthma. If dysphagia is not relieved with steroids, it may be necessary to dilate the figure 25-44. The esophagus on the left shows a stacking of rings, demonstrating eosinophilic esophagus. The esophagus on the right is a normal barium swallow. Figure 25 to 45. The endoscopic appearance of eosinophilic esophagitis is characteristically a series of stacked mucosal rings. Esophagus. Zenker's diverticulum. In the past, the most common recognized sign of cricopharyngeal dysfunction was the presence of a Zenker's diverticulum. Originally described by Ludlow in 1769, the eponym resulted from Zenker's classic clinico-pathologic descriptions of 34 cases published in 1878. Pharyngosophageal diverticula have been reported to occur in one of 1,000 routine barium examinations and classically occur in elderly white males. Zenker's diverticula tend to enlarge progressively with time due to the decreased compliance of the skeletal portion of the cervical esophagus that occurs with aging. Presenting symptoms include dysphagia associated with the spontaneous regurgitation of undigested bland material, often interrupting eating or drinking. On occasion, the dysphagia can be severe enough to cause debilitation and significant weight loss. Chronic aspiration and repetitive respiratory infection are common associated complaints. Once suspected, the diagnosis is established by barium swallow. Endoscopy is usually difficult in the presence of a cricopharyngeal diverticulum and potentially dangerous. Owing to obstruction of the true esophageal lumen by the diverticulum and the attendant risk of diverticular perforation, cricopharyngeal myotomy. The low morbidity and mortality associated with cricopharyngeal and upper esophageal myotomy have encouraged a liberal approach toward its use for almost any problem in the oropharyngeal phase of swallowing. This attitude has resulted in an overall success rate in the relief of symptoms of only 64%. When patients are selected for surgery using radiographic or motility markers of disease, a much higher proportion will benefit. Two methods of cricopharyngosophageal myotomy are in common use, one using traditional surgical approaches and one using rigid laryngoscopy and a linear cutting stapler. Figure 25 to 49. Pharyngeal shoulder pressures and diameter of the pharyngosophageal segment in controls in patients with Zenker's diverticulum. UEs equal to upper esophageal sphincter. Open cricopharyngeal myotomy, diverticulopexy, and diverticulectomy. The myotomy can be performed under local or general anesthesia through an incision along the anterior border of the left sternocleidomastoid muscle. The pharynx and cervical esophagus are exposed by retracting the sternocleidomastoid muscle and carotid sheath laterally in the thyroid, trachea, and larynx medially. When a pharyngosophageal diverticulum is present, localization of the pharyngosophageal segment is easy. The diverticulum is carefully freed from the overlying areolar tissue to expose its neck just below the inferior pharyngeal constrictor and above the cricopharyngeus muscle. It can be difficult to identify the cricopharyngeus muscle in the absence of a diverticulum. A benefit of local anesthesia is that the patient can swallow and demonstrate an area of persistent narrowing at the pharyngosophageal junction. Furthermore, before closing the incision, gelatin can be fed to the patient to ascertain whether the symptoms have been relieved and to inspect the opening of the previously narrowed pharyngosophageal segment. Under general anesthesia and in the absence of a diverticulum, the placement of a nasogastric tube to the level of the manometrically determined cricopharyngeal sphincter helps in localization of the structures. The myotomy is extended cephalad by dividing 1 to 2 centimeters of inferior constrictor muscle of the pharynx, and caudad by dividing the cricopharyngeal muscle and the cervical esophagus for a length of 4 to 5 centimeters. The cervical wound is closed only when all losing of blood has ceased because a hematoma after this procedure is common and is often associated with temporary dysphagia. While the hematoma absorbs, oral alimentation is started the day after surgery. The patient is usually discharged on the first or second postoperative day. Figure 25 to 50. Cross-section of the long esophageal myotomy for motor disorders of the esophageal body. A long esophageal myotomy is indicated for dysphagia caused by any motor disorder characterized by segmental or generalized simultaneous waveforms in a patient whose symptoms are not relieved by medical therapy. Such disorders include diffuse and segmental esophageal spasm, vigorous or type 3 achalasia, and nonspecific motility disorders associated with a mid or epiphrenic esophageal diverticulum. However, the decision to operate must be made by a balanced evaluation of the patient's symptoms, diet, lifestyle adjustments, and nutritional status, with the most important factor being the possibility of improving the patient's swallowing disability. The symptom of chest pain alone is not an indication for a surgical procedure. The identification of patients with symptoms of dysphagia and chest pain who might benefit from a surgical myotomy is difficult. Ambulatory motility studies have shown that when the prevalence of effective contractions drops below 50% during meals, the patient is likely to experience dysphagia. This would suggest that relief from the symptom can be expected with an improvement of esophageal contraction amplitude, or amelioration of non-peristaltic waveforms. Prokinetic agents may increase esophageal contraction amplitude, but they do not alter the prevalence of simultaneous waveforms. Patients in whom the efficacy of esophageal propulsion is severely compromised because of a figure 25 to 59. Prevalence of effective contractions during meal periods in individual normal volunteers, patients without dysphagia, and patients with non-obstructive dysphagia. Figure 25 to 60, esophageal diameter, dysphagia, and esophageal retention in patients with achalasia treated with myotomy and Nissen fundoplication 10 years after treatment. 1,046 to 1,051. High prevalence of simultaneous waveforms usually receive little benefit from medical therapy. In these patients, a surgical myotomy of the esophageal body can improve the patient's dysphagia, provided the loss of contraction amplitude in the remaining peristaltic waveforms caused by the myotomy has less effect on swallowing function than the presence of the excessive simultaneous contractions. This situation is reached when the prevalence of effective waveforms during meals drops below 30%. In patients selected for surgery, preoperative high-resolution manometry is essential to determine the proximal extent of the esophageal myotomy. Most surgeons extend the myotomy distally across the LES to reduce outflow resistance. Consequently, some form of anti-reflux protection is needed to avoid gastroesophageal reflux if there has been extensive dissection of the cardia. In this situation, most authors prefer a partial rather than a full fundoplication in order not to add back resistance that will further interfere with the ability of the myotomized esophagus to empty. If the symptoms of reflux are present preoperatively, 24-hour pH monitoring is required to confirm its presence. The procedure may be performed either open or via thoracoscopy. The open technique is performed through a left thoracotomy in the 6th intercostal space. An incision is made in the posterior mediastinal pleura over the esophagus, and the left lateral wall of the esophagus is exposed. The esophagus is not circumferentially dissected unless necessary. A 2 cm incision is made into the abdomen through the parietal peritoneum at the mid-portion of the left crus. A tongue of gastric fundus is pulled into the chest. This exposes the GEJ and its associated fat pad. The latter is excised to give a clear view of the junction. A myotomy is performed through all muscle layers, extending distally over the stomach 1 to 2 centimeters below the GEJ and proximally on the esophagus over the distance of the metametric abnormality. The muscle layer is dissected from the mucosa laterally for a distance of 1 centimeter. Care is taken to divide all minute muscle bands, particularly in the area of the GEJ. The gastric fundic tongue is sutured to the margins of the myotomy over a distance of 3 to 4 centimeters and replaced into the abdomen. This maintains separation of the muscle and acts as a partial fundoplication to prevent reflux. Figure 25 to 61. Technique of long myotomy. A. Exposure of the lower esophagus through the left 6th intercostal space and incision of the mediastinal pleura in preparation for surgical myotomy. B. Location of a 2 cm incision made through the phrenosophageal membrane into the abdomen along the midlateral border of the left crus. C. Retraction of tongue of gastric fundus into the chest through the previously made incision. D. Removal of the gastroesophageal fat pad to expose the gastroesophageal junction. E. A myotomy down to the mucosa is started on the esophageal body. F. Completed myotomy extending over the stomach for 1 centimeter. G. Reconstruction of the cardia after a myotomy, illustrating the position of the sutures used to stitch the gastric fundic flap to the margins of the myotomy. H. Reconstruction of the cardia after a myotomy, illustrating the intra-abdominal position of the gastric tongue, covering the distal 4 centimeters of the myotomy. Figure 25 to 61. If an epiphrenic diverticulum is present, it is excised by dividing the neck with a stapler size for the thickness of the diverticulum, followed by a closure of the muscle over the staple line, when possible. The myotomy is then performed on the opposite esophageal wall. If a midesophageal diverticulum is present, the myotomy is made so that it includes the muscle around the neck, and the diverticulum is suspended by attaching it to the paravertebral fascia of the thoracic vertebra above the level of the diverticular neck. Before performing any operation for an esophageal diverticulum, it is wise to endoscope the patient to wash all food and other debris from the diverticulum. The results of myotomy for motor disorders of the esophageal body have improved in parallel with the improved preoperative diagnosis afforded by manometry. Previous published series report between 40% and 92% improvement of symptoms, but interpretation is difficult due to the small number of patients involved and the varying criteria for diagnosis of the primary motor abnormality. When myotomy is accurately done, 93% of the patients have effective palliation of dysphagia after a mean follow-up of 5 years, and 89% would have the procedure again if it was necessary. Most patients gain or maintain rather than lose weight after the operation. Postoperative motility studies show that the myotomy reduces the amplitude of esophageal contractions to near zero and eliminates simultaneous peristaltic waves. If the benefit of obliterating the simultaneous waves exceeds the adverse effect on bolus propulsion caused by the loss of peristaltic waveforms, the patient's dysphagia is likely to be improved by the procedure. If not, the patient is likely to continue to complain of dysphagia and to have little improvement as a result of the operation. The thoracoscopic technique may be performed through the left or right chest. There's been little experience gained with doing adequate operations through left thoracoscopy, so most surgeons will combine a right thoracoscopic long myotomy with an abdominal approach for Heller myotomy and partial fundoplication. These two procedures may be done at the same setting by double positioning the patient, or they may be done at two operations. If this is the case, it is best to do the abdominal component first, as the esophageal outflow obstruction is the source of most of the symptoms. Performing abdominal myotomy may be all that is required. A new procedure, peroral endoscopic myotomy, allows a long myotomy to be performed from the lumen of the esophagus with an endoscope. This procedure is attractive for, at a minimum, those with type 3 achalasia, where it is necessary to divide esophagogastric circular muscle on both sides of the diaphragm to the extent that might not be possible with laparoscopy or thoracoscopy alone. The POEM procedure is started by opening the esophageal mucosa several centimeters above the spastic segment with a needle knife electrosurgery device passed through an endoscope. A long submucosal plane is developed with the endoscope down to and below the LEEs. The circular muscle of the LEEs and the esophagus is divided with endoscopic electrosurgery all the way back until normal esophagus is reached. The submucosal entry site in the esophagus is then closed with endoscopic clips. While the results of POEM are still accumulating, the procedure is attractive because it is extremely minimally invasive and can be done on an outpatient basis. Epiphrenic diverticula cannot be treated with POEM and are most frequently addressed with laparoscopic access in combination with a laparoscopic division of the LEs. If the diverticulum can be completely mobilized through the hiatus, it may be safely excised from below. The neck of the diverticulum is transected with a GIA stapler after passage of a 48 Fahrenheit dilator. Not infrequently, the diverticulum is sufficiently large that access to the neck of the diverticulum across the hiatus is quite difficult. Additionally, the inflammatory reaction to the diverticulum may further make the transhiatal dissection difficult. Under these circumstances, it is safer to perform the diverticulectomy through a right thoracoscopic approach, either at the time of the initial procedure or at a later date, depending upon the frailty of the patient. Following diverticulectomy, it is critical that the esophageal staple line be treated with a great deal of care. Closure of the muscle over the staple line is preferable. Additionally, the patient is kept in PO or on clear liquids for 2 days, and a contrast study is obtained before advancing to a full liquid or mushy food diet. Solid foods are withheld for 2 weeks to decrease the likelihood of staple line leak. Buttressing or sealing the staple line with fibrin glue is also an attractive option. Figure 25 to 62. A. Epiphrenic diverticula are situated above the lower esophageal sphincter on right side of esophagus. B. Stapler amputates neck of diverticulum. C. Muscle reapproximated over staple line and Heller myotomy is performed. Myotomy of the lower esophageal sphincter. Second only to reflux disease, achalasia is the most common functional disorder of the esophagus to require surgical intervention. The goal of treatment is to relieve the functional outflow obstruction secondary to the loss of relaxation and compliance of the LES. This requires disrupting the lay muscle. When performed adequately and done early in the course of disease, less myotomy results in symptomatic improvement with the occasional return of esophageal peristalsis. Reduction in lay resistance can be accomplished intraluminally by hydrostatic balloon dilation, which ruptures the sphincter muscle, by botulinum toxin injection, or by a surgical myotomy that cuts the sphincter. The difference between these three methods appears to be the greater likelihood of reducing sphincter pressure to less than mmHg by surgical myotomy compared with hydrostatic balloon dilation. However, patients whose sphincter pressure has been reduced by hydrostatic balloon dilation to less than 10 mmHg have an outcome similar to those after surgical myotomy. Botulinum toxin injection may achieve similar results, but it has a longer duration of action that may be measured in weeks or months rather than years. Botulinum toxin injection may best be used as a diagnostic tool when it is not clear whether a hypertensive LEs is the primary cause of dysphagia. Responsiveness to botulinum toxin injection may predict a good response to Heller myotomy. The therapeutic decisions regarding the treatment of patients with achalasia center on 4 issues. The first issue is the question of whether newly diagnosed patients should be treated with pneumatic dilation or a surgical myotomy. Long-term follow-up studies have shown that pneumatic dilation, figure, prevalence of clinical remission in patients stratified according to post-dilatation, lower esophageal sphincter pressures greater than or lieutenant 10, 2,135 to 2,141. Achieves adequate relief of dysphagia and pharyngeal regurgitation of patients. Close follow-up is required, and if dilation fails, myotomy is indicated. For those patients who have a dilated and tortuous esophagus or an associated hiatal hernia, balloon dilation is dangerous and surgery is the better option. The outcome of the one controlled randomized study comparing the two modes of therapy suggests that surgical myotomy as a primary treatment gives better long-term results. Several randomized trials comparing laparoscopic cardiomyotomy with balloon dilation or botulinum toxin injection have favored the surgical approach as well. Figure 25 to 64. Summary of long-term studies reporting the proportion of patients with complete relief or minimal dysphagia stratified according to type of treatment. Although it has been reported that a myotomy after previous balloon dilation is more difficult, this has not been the experience of these authors unless the cardia has been ruptured in a sawtooth manner. In this situation, operative intervention, either immediately or after healing has occurred, can be difficult. Similarly, myotomy after botulinum toxin injection has reported to be more difficult, but this is largely a function of the submucosal inflammatory response, which may be a bit unpredictable and is most intense in the first 6 to 12 weeks after injection. It is important to wait at least 3 months after botulinum toxin injection to perform cardiomyotomy to minimize the risk of encountering dense inflammation. The second issue is the question of whether a surgical myotomy should be performed through the abdomen or the chest. Myotomy of the LEEs can be accomplished via either an abdominal or thoracic approach. In the absence of a previous upper abdominal surgery, most surgeons prefer the abdominal approach to less myotomy, as laparoscopy results in less pain and a shorter length of stay than thoracoscopy. In addition, it is a bit easier to ensure a long gastric myotomy when the approach is transabdominal. The third issue, and one that has been long debated, is the question of whether an anterior flux procedure should be added to a surgical myotomy. Excellent results have been reported following meticulously performed myotomy without an anterior flux component. Retrospective studies with long-term follow-up of large cohorts of patients undergoing Heller myotomy demonstrated that after 10 years, more than 50% of patients had reflux symptoms without a fundoplication. In a recent randomized clinical trial, 7% of patients undergoing DOR fundoplication following lesmyotomy had abnormal 24-hour pH probes, and 42% of patients with a myotomy only had abnormal reflux profiles. If an anterior flux procedure is used as an adjunct to esophageal myotomy, a complete fundoplication should be avoided. Rather, a 270-degree Belsey fundoplication, a Toupet posterior 180-degree fundoplication, or a DOR anterior 180-degree fundoplication should be used to avoid the long-term esophageal dysfunction secondary to the outflow obstruction afforded by the fundoplication itself. The fourth issue centers on whether or not a cure of this disease is achievable. Long-term follow-up studies after surgical myotomy have shown that late deterioration in results occurs after this procedure, regardless of whether an anterior flux procedure is done, and also after balloon dilation. Even when the sphincter pressure is reduced to below mmH, it may be that even though a myotomy or balloon rupture of the less muscle reduces the outflow obstruction at the cardia, the underlying motor disorder in the body of the esophagus persists and deteriorates further with the passage of time, leading to increased impairment of esophageal emptying. The earlier an effective reduction in outflow resistance can be accomplished, the better the outcome will be, and the more likely some esophageal body function can be restored. In performing a surgical myotomy of the LES, there are 4 important principles: complete division of all circular and collar sling muscle fibers, adequate distal myotomy to reduce outflow resistance, undermining of the muscularis to allow wide separation of the esophageal muscle, and prevention of postoperative reflux. In the past, a drawback of a surgical myotomy was the need for an open procedure, which often deterred patients from choosing the best treatment option for achalasia. With the advent of minimally invasive surgical techniques 2 decades ago, laparoscopic cardiomyotomy has become the treatment of choice for most patients with achalasia. Open esophageal myotomy. Open techniques of distal esophageal myotomy are rarely used outside reoperations. In fact, primary procedures can almost always be successfully completed via laparoscopy. A modified Heller myotomy can be performed through a left thoracotomy incision in the 6th intercostal space along the upper border of the 7th rib. The esophagus and a tongue of gastric fundus are exposed as described for a long myotomy. A myotomy through all muscle layers is performed, extending distally over the stomach to 1 to 2 centimeters below the junction. And proximally on the esophagus for the CM, The cardia is reconstructed by suturing the tongue of gastric fundus to the margins of the myotomy to prevent rehealing of the myotomy site and to provide reflux protection in the area of the divided sphincter. If an extensive dissection of the cardia has been done, a more formal Belsey repair is performed. The tongue of gastric fundus is allowed to retract into the abdomen. Traditionally, nasogastric drainage is maintained for 6 days to prevent distension of the stomach during healing. An oral diet is resumed on the 7th day after a barium swallow study shows unobstructed passage of the bolus into the stomach without extravasation. In a randomized long-term follow-up by ch16 and colleagues of 81 patients treated for achalasia, either by forceful dilation or by surgical myotomy. Myotomy was associated with a significant increase in the diameter at the GEJ and a decrease in the diameter at the middle third of the esophagus on follow-up radiographic studies. There was a greater reduction in sphincter pressure and improvement in the amplitude of esophageal contractions after myotomy. After dilation, 13% of patients regained some peristalsis, compared with 28% after surgery. These findings were shown to persist over a year follow-up period, at which time of those treated with surgical myotomy were doing well. Of those who were treated with dilation, only 54% were doing well, while 16% required retilation and 22% eventually required surgical myotomy to obtain relief. If simultaneous esophageal contractions are associated with the sphincter abnormality, the so-called vigorous achalasia, then the myotomy should extend over the distance of the abnormal motility as mapped by the preoperative motility study. Failure to do this will result in continuing dysphagia and a dissatisfied patient. The best objective evaluation of improvement in the patient following either balloon dilation or myotomy is a scintigraphic measurement of esophageal emptying time. A good therapeutic response improves esophageal emptying toward normal. However, some degree of dysphagia may persist despite improved esophageal emptying due to disturbances in esophageal body function. When an anti-reflux procedure is added to the myotomy, it should be a partial fundoplication. A 360-degree fundoplication is associated with progressive retention of swallowed food, regurgitation, and aspiration to a degree that exceeds the patient's preoperative symptoms. Laparoscopic cardiomyotomy, more commonly known as a laparoscopic Heller myotomy, after Ernst Heller, a German surgeon who described a double myotomy in 1913. The laparoscopic approach is similar to the Nissen fundoplication in terms of the trocar placement and exposure and dissection of the esophageal hiatus. The procedure begins by division of the short gastric vessels in preparation for fundoplication. Exposure of the GEJ via removal of the gastroesophageal fat pad follows. The anterior vagus nerve is swept right laterally along with the fat pad. Once completed, the GEJ and distal to cm of esophagus should be bared of any overlying tissue and generally follows dissection of the GEJ. A distal esophageal myotomy is performed. It is generally easiest to begin the myotomy 1 to 2 centimeters above the GEJ in an area above that of previous botulinum toxin injections or balloon dilation. Either scissors or a hook type electrocautery can be used to initiate the incision in the longitudinal and circular muscle. Distally, the myotomy is carried across the GEJ and onto the proximal stomach for approximately 2 to 3 centimeters. After completion, the muscle edges are separated bluntly from the esophageal mucosa for approximately 50% of the esophageal circumference. An anti-reflux procedure follows completion of the myotomy. Either an anterior hemifundoplication augmenting the angle of his or posterior partial fundoplication can be performed. The Dior type fundoplication is slightly easier to perform and it does not require disruption of the normal posterior gastroesophageal attachments. Peroral endoscopic myotomy. The POEM procedure was developed in Japan. It is the ultimate minimally invasive myotomy, as it requires no incisions through the skin. With the POEM procedure, a very effective myotomy is performed entirely from the lumen of the esophagus. The POEM procedure is started by opening the esophageal mucosa cm above the lower esophageal sphincter with a needle knife electrosurgery device passed through an endoscope. A long submucosal plane is developed with the endoscope down to and below the les. The circular muscle of the les, above and below the gastroesophageal junction, is divided with endoscopic electrosurgery. The submucosal entry site in the esophagus is then closed with endoscopic clips. While the results of POEM are still accumulating, the procedure is attractive because it is extremely minimally invasive and can be done on an outpatient basis. The major downside of POEM is that an effective anti-reflux valve cannot be created, exposing the patient to a 40% to 50% risk of GERD post-procedure. Outcome assessment of the therapy for achalasia. Critical analysis of the results of therapy for motor disorders of the esophagus requires objective measurement. The use of symptoms alone as an endpoint to evaluate therapy for achalasia may be misleading. The propensity for patients to unconsciously modify their diet to avoid difficulty swallowing is underestimated, making an assessment of results based on symptoms unreliable. Insufficient reduction in outflow resistance may allow progressive esophageal dilation to develop slowly, giving the impression of improvement because the volume of food able to be ingested with comfort increases. A variety of objective measurements may be used to assess success, including less pressure, esophageal baseline pressure, and scintigraphic assessment of esophageal emptying time. Esophageal baseline pressure is usually negative compared to gastric pressure, given that the goal of therapy is to eliminate the outflow resistance of a non-relaxing sphincter. Measurements of improvements in esophageal baseline pressure and scintigraphic transit time may be better indicators of success, but these are rarely reported. Eckert and associates investigated whether the outcome of pneumatic dilation in patients with achalasia could be predicted on the basis of objective measurements. Post-dilation less pressure was the most valuable measurement for predicting long-term clinical response. A post-dilatation sphincter pressure less than an mmHg predicted a good response. Approximately 50% of the patients studied had post-dilatation sphincter pressures between 10 and 20 mmHg, with a 2-year remission rate of 71%. More important, 16 of 46 patients were left with a post-dilatation sphincter pressure of greater than 20 mmHg and had an unacceptable outcome. Overall, only 30% of patients dilated remained in symptomatic remission at 5 years. Bonavina and colleagues reported good to excellent results with transabdominal myotomy and door fundoplication in 94% of patients after a mean follow-up of 5.4 years. No operative mortality occurred in either of these series, attesting to the safety of the procedure. Malthaner and Pearson reported the long-term clinical results in 35 patients with achalasia having a minimum follow-up of 10 years. 22 of these patients underwent primary esophageal myotomy and Belsey hemifundoplication at the Toronto General Hospital. Excellent to good results were noted in 95% of patients at 1 year, declining to 68%, 69%, and 67% at 10, 15, and 20 years, respectively. 2 patients underwent early reoperation for an incomplete myotomy, and 3 underwent an esophagectomy for progressive disease. They concluded that there was a deterioration of the initially good results after surgical myotomy and hiatal repair for achalasia, which is due to late complications of gastroesophageal reflux. Ellis reported his lifetime experience with transthoracic short esophageal myotomy without an anterior flux procedure. 179 patients were analyzed at a mean follow-up of years, ranging from months to years. Overall, 89% of patients were improved at the 9-year mark. He also observed that the level of improvement deteriorated with time, with excellent results decreasing from 54% at 10 years to 32% at 20 years. He concluded that a short transthoracic myotomy without an anterior flux procedure provides excellent long-term relief of dysphagia and, contrary to Malthaner and Pearson's experience, does not result in complications of gastroesophageal reflux. Both studies document nearly identical results 10 to 15 years following the procedure, and both report deterioration over time, probably due to progression of the underlying disease. The addition of an anterior flux procedure, if the operation is performed transthoracically, has no significant effect on the outcome. Figure 25 to 65. A. Longitudinal muscle is divided. B. Mechanical disruption of lower esophageal sphincter muscle fibers. C. Myotomy must be carried across gastroesophageal junction. D. Gastric extension should equal 2 to 3 centimeters. E. Anterior fundoplication is sutured to the diaphragmatic arch. F. Posterior fundoplication is sutured to cut edges of myotomy, e.g. ch16 equal to esophagogastric junction. Figure, table, data from Malthaner, R.A. et al. Long-term results in surgically managed esophageal achalasia and thorac surg. 1994, 58, 1,343, Ellis F.H. Jr. Osophagomyotomy for achalasia, a 22-year experience. B.R.J. Surg, 1993, 80, 882, and Goldburn I.A., and others long-term results of Heller's operation for achalasia. J.R. Cole, Surg Ed B., 1985, 010. The outcome of laparoscopic myotomy and hemifundoplication has been well documented. 2 reports of over 100 patients have documented relief of dysphagia in 93% of patients. Richter and co-workers reviewed published reports to date, including 254 patients with an average success rate of 93% at 2.5 years. Conversion to an open procedure occurs in 2 of patients. Complications are uncommon, occurring in LT of patients. Intraoperative complications consist largely of mucosal perforation and have been more likely to occur after botulinum toxin injection. The incidence of objective reflux disease, as evidenced by abnormal acid exposure, is less than 10%. A number of randomized clinical trials in the past decade have compared the outcomes of laparoscopic Heller myotomy to pneumatic dilation and to botulinum toxin injection. In each of these trials, laparoscopic Heller myotomy and partial fundoplication was superior to the alternative treatment. Lastly, a randomized clinical trial examining the need for fundoplication following Heller myotomy demonstrated a great deal more reflux in patients without fundoplication and no better swallowing in the Heller-only group. The best treatment for achalasia is a laparoscopic Heller myotomy and partial fundoplication. The role of POEM in the management of classic achalasia is yet to be established. Esophageal resection for end-stage motor disorders of the esophagus, patients with dysphagia and long-standing benign disease, whose esophageal function has been destroyed by the disease process or multiple previous surgical procedures, are best managed by esophagectomy. Fibrosis of the esophagus and cardia can result in weak contractions and failure of the distal esophageal sphincter to relax. The loss of esophageal contractions can result in the stasis of food, esophageal dilatation, regurgitation, and aspiration. The presence of these abnormalities signals end-stage motor disease. In these situations, esophageal replacement is usually required to establish normal alimentation. Before proceeding with esophageal resection for patients with end-stage benign disease, the choice of the organ to substitute for the esophagus should be considered. The choice of replacement is affected by a number of factors, as described later in techniques of esophageal reconstruction. If minimally invasive esophagectomy is to be performed, thoracoscopic dissection should be combined with abdominal dissection. Attempts at mistranchiatal esophagectomy for the massively dilated esophagus may result in large volume bleeding from mediastinal vessels that become enlarged with esophageal dilation. And such bleeding must be directly controlled for hemostasis to be adequate and the operation to be safe. Carcinoma of the esophagus. Squamous carcinoma accounts for the majority of esophageal carcinomas worldwide. Its incidence is highly variable, ranging from approximately 20 per 100,000 in the United States and Britain to 160 per 100,000 in certain parts of South Africa and the Henan province of China, and even 540 per 100,000 in the Guryev district of Kazakhstan. The environmental factors responsible for these localized high-incidence areas have not been conclusively identified, though additives to local foodstuffs and mineral deficiencies have been suggested. In Western societies, smoking and alcohol consumption are strongly linked with squamous carcinoma. Other definite associations link squamous carcinoma with long-standing achalasia, lie strictures, tylosis, and human papillomavirus. Adenocarcinoma of the esophagus, once an unusual malignancy, is diagnosed with increasing frequency and now accounts for more than of esophageal cancer in most Western countries. The shift in the epidemiology of esophageal cancer from predominantly squamous carcinoma seen in association with smoking and alcohol to adenocarcinoma in the setting of B is one of the most dramatic changes that has occurred in the history of human neoplasia. Although esophageal carcinoma is a relatively uncommon malignancy, its prevalence is exploding, largely secondary to the well-established association among gastroesophageal reflux, B, and esophageal adenocarcinoma. Although B was once a nearly uniformly lethal disease, survival has improved slightly because of advances in the understanding of its molecular biology, screening and surveillance practices, improved staging, minimally invasive surgical techniques, and neoadjuvant therapy. Furthermore, the clinical picture of esophageal adenocarcinoma is changing. It now occurs not only considerably more frequently, but also in younger patients, and it is often detected at an earlier stage. These facts support rethinking the traditional approach of assuming palliation is appropriate in all patients. The historical focus on palliation of dysphagia in an elderly patient with comorbidities should change when dealing with a young patient with dependent children and a productive life ahead. The potential for cure becomes of paramount importance. The gross appearance resembles that of squamous cell carcinoma. Microscopically, adenocarcinoma almost always originates in Barrett's mucosa and resembles gastric cancer. Rarely, it arises in the submucosal glands and forms intramural growths that resemble the mucoepidermal and adenoid cystic carcinomas of the salivary glands. The most important etiologic factor in the development of primary adenocarcinoma of the esophagus is a metaplastic columnar lined or Barrett's esophagus, which occurs in approximately 10% to 15% of patients with GERD. When studied prospectively, the incidence of adenocarcinoma in a patient with B is 1 in to patient years of follow-up. Although this risk appears to be small, it is at least 40 to 60 times that expected for a similar population without B. This risk is similar. The gallbladder is a pear-shaped sac that measures around 7 to 10 centimeters long, with an average capacity of 30 to 50 mL. When obstructed, the gallbladder can distend markedly and contain up to 300 ml of fluid. The gallbladder is located in an anatomic fossa on the inferior surface of the liver. Cantill's line, a vertical plane running from the gallbladder fossa anteriorly to the inferior vena cava, posteriorly divides the liver into right and left lobes. The gallbladder itself is divided into 4 anatomic areas: the fundus, the body, the infundibulum, and the neck. The fundus is the rounded, blind end that normally extends 1 to 2 centimeters beyond the liver's margin and contains most of the smooth muscle of the organ. The body functions as the main storage area and contains most of the elastic tissue, allowing for distension. As the body tapers towards the neck of the gallbladder, a mucosal outpouching is present at the junction of the neck and the cystic duct, known as the infundibulum, or Hartmann's pouch. Beyond this, the neck of the gallbladder lies in the deepest part of the gallbladder fossa and can extend slightly into the free portion of the hepatoduodenal ligament, where it connects with the cystic duct. The same peritoneal lining that covers the liver extends to cover the fundus and the inferior surface of the gallbladder. Occasionally, part or all of the gallbladder is embedded deep inside the liver parenchyma. 1,401, 1,410. Rarely, the gallbladder has a complete peritoneal covering on all sides and is suspended in a mesentery off the inferior surface of the liver. The mucosal lining of the gallbladder is formed by a single, highly redundant, simple columnar epithelium that contains cholesterol and fat globules. The mucus secreted into the gallbladder originates in tubuloalveolar glands that are found in the mucosal lining of the infundibulum and neck of the gallbladder, but are absent from the body and fundus. The epithelial lining of the gallbladder is supported by a lamina propria. The gallbladder differs histologically from the rest of the gastrointestinal tract in that it lacks a muscularis mucosa and submucosa. The muscular layer has circular, longitudinal, and oblique fibers, but without well-defined layers. The adventitia contains connective tissue, nerves, vessels, lymphatics, and adipocytes. The gallbladder is covered by serosa, except where the gallbladder is embedded in the liver. The cystic artery that supplies the gallbladder is usually a branch of the right hepatic artery. The course of the cystic artery may vary, but it nearly always is found within the hepatocystic triangle, the area bound by the cystic duct, common hepatic duct, and the inferior edge of the liver. When the cystic artery reaches the neck of the gallbladder, it divides into anterior and posterior divisions. Venous return is carried either through small veins that enter directly into the liver, or rarely to a large cystic vein that carries blood back to the portal vein. Gallbladder lymphatics drain into nodes. Key: 1. The physiology of the gallbladder, biliary tree, and sphincter of ODI are regulated by a complex interplay of hormones and neuronal inputs designed to coordinate bile release with food consumption. Dysfunctions related to this activity are linked to the development of gallbladder pathologies as described in this chapter. 2. In Western countries, the most common type of gallstones are cholesterol stones. The pathogenesis of these stones relates to supersaturation of bile with cholesterol and subsequent. 3. Laparoscopic cholecystectomy has been demonstrated to be safe and effective and it has become the treatment of choice for symptomatic gallstones. Knowledge of the various anatomic anomalies of the cystic duct and artery is critical in guiding the dissection of these structures and avoiding injury to the common bile duct during cholecystectomy. 4 common bile duct injuries, although uncommon, can be devastating to patients. Proper exposure of a hepatocyst triangle to obtain the critical view of safety and careful identification of the anatomic structures are keys to avoiding these injuries. Once a bile duct injury is diagnosed, the best outcomes are seen at large referral centers with experienced biliary surgeons, and patient transfer may be required. 5, the main risk factor for gallbladder disease in Western countries is cholelithiasis. The main complications include cholecystitis, cholelithiasis, cholangitis, and biliary pancreatitis. Cholelithiasis is also the major risk factor for the development of gallbladder cancer. 6, carcinomas of the gallbladder or bile ducts generally have a poor disease process and have poor response to chemotherapy and radiation. Surgery offers the best chance for survival and has good long-term outcomes in patients with early proper exposure of a hepatocystic at the neck of the gallbladder. Frequently, a visible lymph node overlies the insertion of the cystic artery into the gallbladder wall. The gallbladder receives parasympathetic, sympathetic, figure 32:1, anterior aspect of the biliary and sensory innervation through nerve fibers running largely through the gastrohepatic ligament. Parasympathetic fibers arise from the hepatic branches of the vagus nerve to stimulate activity in the gallbladder, bile ducts, and liver. These vagal branches also have peptide-containing nerves containing agents such as substance P, somatostatin, enkephalins, and vasoactive. Sensory branches of the gallbladder, liver, and bile ducts pass through the celiac plexus and control gallbladder relaxation and mediate the pain of biliary colic. Bile ducts. The extrahepatic biliary tree consists of the right and left hepatic ducts, the common hepatic duct, the cystic duct, and the common bile duct. Exiting the liver. The extrahepatic biliary tree consists of the right and left hepatic ducts, the common hepatic duct, the cystic duct, and the common bile duct. Exiting the liver, the left hepatic duct is longer than the right and has a greater propensity for dilatation as a consequence. Their emergence from the liver to form the common hepatic duct. The common hepatic duct typically extends 1 to 4 centimeters, has a diameter of approximately mm, and lies anterior to the portal vein and to the right of the hepatic artery. The cystic duct exits the gallbladder and joins the common hepatic duct at an acute angle to form the common bile duct. The segment of the cystic duct immediately adjacent to the gallbladder neck bears a variable number of mucosal folds called the spiral valves of Heister. While they do not have any valvular function, they can make cannulation off the cystic duct difficult. The length and course of the cystic duct can be quite variable. It may be short or absent and have a high union with the hepatic duct, or it may be long and running parallel to, behind, or spiraling around to the common hepatic duct before joining it. Sometimes as far distally as at the duodenum. Variations of the cystic duct and its point of union with the common hepatic duct are surgically important, and misidentification can lead to bile duct injuries. The union of the cystic duct and the common hepatic duct marks the start of the common bile duct. This segment is typically about 7 to 11 centimeters in length and 5 to 10 millimeters in diameter, though its diameter can increase slightly with age and following cholecystectomy. The upper third passes downward in the free edge of the hepatoduodenal ligament, to the right of the hepatic artery and anterior to the portal vein. The middle third of the common bile duct curves behind the first portion of the duodenum and diverges laterally from the portal vein and the hepatic arteries. The lower third can curve behind the head of the pancreas in a groove or traverse through it to enter the wall of the second portion of the duodenum. The duct then runs obliquely downward within the wall of the duodenum for to cm before opening on a papilla of mucous membrane, about cm distal to the pylorus. The union of the common bile duct and the main pancreatic duct follows one of 3 configurations. In about people, these ducts unite outside the duodenal wall and traverse the duodenal wall as a single duct. In about 20%, they join within the duodenal wall and have a short or no common duct, but open through the same opening into the duodenum. In about 10%, they exit separate openings into the duodenum, termed pancreas divisum. The sphincter of Oddi, a thick coat of circular smooth muscle, surrounds the common bile duct at the ampulla of Vater. It controls the flow of bile, and in some cases pancreatic juice, into the duodenum. The extrahepatic bile ducts are lined by a columnar mucosa with numerous mucus glands that are concentrated in the common bile duct. A fibroareolar tissue containing scant, smooth muscle cells surrounds the mucosa. A distinct muscle layer is not present in the human common bile duct. The arterial supply to the bile ducts is derived from the gastroduodenal and the right hepatic arteries, with major trunks running along the medial and lateral walls of the common duct. The nerve supply to the common bile duct is the same as for the gallbladder, with the density of nerve fibers and ganglia increasing near the sphincter of OD. Figure, the sphincter of OD, anatomic variance. The classic description of the extrahepatic biliary tree and its arteries applies only in about 1/3 of patients. The gallbladder may have abnormal positions, be intrahepatic, be rudimentary, or have anomalous forms or duplications. A partially or completely intrahepatic gallbladder is associated with an increased incidence of cholelithiasis and may be encountered at the time of cholecystectomy. Isolated congenital absence of the gallbladder is very rare, with a reported incidence of 0.03%. Before the diagnosis is made, the presence of an intrahepatic gallbladder or anomalous position must first be ruled out. Duplication of the gallbladder with 2 separate cavities and 2 separate cystic ducts has an incidence of about 1 in every 4,000 persons. This occurs in 2 major varieties. The more common form, in which each gallbladder has its own cystic duct that empties independently into the same or different parts of the extrahepatic biliary tree, and the less common variant, in which the 2 cystic ducts merge before they enter the common bile duct. Duplication is only clinically important when some pathologic process affects one or both organs. Even rarer variants include a left-sided gallbladder, retrodisplacement of the gallbladder at the posterior inferior surface of the liver, transverse positioning of the gallbladder, or a floating gallbladder in which the gallbladder is hanging by mesentery. Additional small bile ducts may drain directly from the liver fossa into the body of the gallbladder. If present but not recognized at the time of a cholecystectomy, a bile leak and subsequent accumulation of bile may occur in the abdomen. An accessory right hepatic duct occurs in about 5% of cases. Variations in how the common bile duct enters the duodenum are described earlier in the bile duct section. Anomalies of the hepatic artery and the cystic artery are quite common, occurring in as many as 50% of cases. While the right hepatic artery usually originates from the proper hepatic branch of the celiac trunk, up to a patient will have a replaced right hepatic artery coming off the superior mesenteric artery. In about 5% of cases, there are 2 right hepatic arteries, one from the proper hepatic artery and the other from the superior mesenteric artery. While the right hepatic artery typically runs posterior to the bile ducts, variations may allow it to course anterior to the common duct, making it vulnerable during surgical procedures, particularly if it runs parallel to the cystic duct or in the mesentery of the gallbladder. The cystic artery arises from the right hepatic artery in about 90% of cases, but it may arise from the left hepatic, common hepatic, gastroduodenal, or superior mesenteric arteries. Figure 32-4, floating gallbladder suspended on mesentery. Figure 32-5, variations in the arterial supply to the gallbladder. A cystic artery from right hepatic artery, about 80% to 90%. B, cystic artery off the right hepatic artery, arising from the superior mesenteric artery, about 10%. C, 2 cystic arteries, one from the right hepatic, the other from the common hepatic artery, rare. D, 2 cystic arteries, one from the right hepatic, the other from the left hepatic artery, rare. E, the cystic artery branching from the right. Bile formation and composition. The liver produces bile continuously and excretes it into the bile canaliculi. Bile leaves the liver through the right and left hepatic ducts. A variety of diagnostic modalities are available for the patient with suspected disease of the gallbladder or bile ducts. In 1924, the diagnosis of gallstones was revolutionized by the introduction of oral cholecystography by Graham and Cole. For decades, it was the mainstay of investigation for gallstones. It involved oral administration of a radiopaque compound that is absorbed, excreted by the liver, and passed into the gallbladder. Stones are noted on a film as filling defects in a visualized, pacified gallbladder. In the later half of the 20th century, biliary imaging improved dramatically with the development of hepatobiliary scintigraphy, as well as transhepatic and endoscopic retrograde cholangiography, which allowed for more detailed imaging of the biliary tree. Later, ultrasonography, computed tomography, and magnetic resonance imaging would further improve the ability to image the biliary tract. Blood tests. When patients with suspected diseases of the gallbladder or the extrahepatic biliary tree are evaluated, a complete blood count and liver function tests are routinely requested. An elevated white blood cell count may indicate or raise suspicion of acute cholecystitis. If associated with an elevation of bilirubin, alkaline phosphatase, and transaminases, cholangitis should be suspected. Cholestasis is generally characterized by an elevation of conjugated bilirubin and a rise in alkaline phosphatase, but it may have no transaminitis. Such a pattern may suggest cholelithiasis or an obstructing lesion such as a stricture or cholangiocarcinoma. In patients with simple symptomatic cholelithiasis, biliary colic, or chronic cholecystitis, blood tests will often be normal. Transabdominal ultrasonography. Transabdominal ultrasound is the initial investigation of any patient suspected to have disease of the biliary tree. It is non-invasive, painless, does not submit the patient to radiation, can be performed on critically ill patients. Adjacent organs can also frequently be examined at the same time. However, its reliability and interpretation are dependent upon the skills and experience of the operator. In addition, obese patients, patients with ascites, and patients with distended bowel may be difficult to examine with ultrasound, as the quality of the images obtained in these situations can be poor. Ultrasound will show stones in the gallbladder with sensitivity and specificity of greater than 90% and can also reliably detect other pathologies of the biliary tree. Stones are acoustically dense and reflect the ultrasound waves back to the ultrasonic transducer. Because stones block the passage of sound waves to the region behind them, they also produce an acoustic shadow. Stones move with changes in position. Polyps, on the other hand, may be calcified and reflect shadows, but they do not move with change in posture. Some stones form a layer in the gallbladder. Others form sediment or sludge. A thickened gallbladder wall, pericholecystic fluid, and local tenderness with direct pressure by the ultrasound probe over the fundus of the gallbladder may indicate acute cholecystitis. When a stone obstructs the neck of the gallbladder may become very large but thin-walled. A contracted, thick-walled gallbladder can be indicative of chronic cholecystitis. The extrahepatic bile ducts are also well visualized by transabdominal ultrasound, with the exception of the retroduodenal portion. Dilation of the biliary tree in a patient with jaundice suggests an extrahepatic obstruction as the cause for the jaundice. Frequently, the site and sometimes the cause of the obstruction can be determined by ultrasound. Small stones in the common bile duct frequently get lodged at the distal end of it behind the duodenum and are, therefore, difficult to detect. A dilated common bile duct on ultrasound, small stones in the gallbladder, and a classic clinical presentation allows one to assume that a stone or stones are causing the obstruction. Periampulary tumors can be difficult to diagnose on ultrasound, but above the retroduodenal portion, the level of obstruction and the cause may be visualized quite well. Ultrasound can also be helpful in evaluating tumor invasion and flow in the portal vein, an important guideline for resectability of periampulary tumors. Computed tomography. Abdominal CT scans are frequently used in the workup of undifferentiated abdominal pain and thus often diagnose gallbladder. Figure. Computed tomography scan. Disease. CT scanning is inferior to ultrasonography in diagnosing gallstones, but is similar in sensitivity for acute cholecystitis. The major application of CT scan, however, is to define the course and status of the extrahepatic biliary tree and adjacent structures, and to evaluate for alternate causes of a patient's clinical presentation. CT is also the initial test of choice in evaluating patients with suspected malignancy of the gallbladder, the extrahepatic biliary system, or nearby organs such as the head of the pancreas. Use of CT scan is an integral part of the differential diagnosis of obstructive jaundice of unknown origin. Hepatobiliary scintigraphy. Hepatobiliary scintigraphy or hepatobiliary immunodiacetic acid scanning is another option for non-invasive evaluation of the liver, gallbladder, bile ducts, and duodenum that provides both anatomic and functional information. 99-methacnetium labeled derivatives of immunodiacetic acid are injected intravenously, taken up by the Kupffer cells in the liver, and excreted in the bile. Uptake by the liver is usually detected within 10 minutes, and the gallbladder, bile ducts, and duodenum are typically visualized within 60 minutes in fasting subjects. The primary use of biliary scintigraphy is in the diagnosis of acute cholecystitis, which appears as a non-visualized gallbladder with prompt filling of the common bile duct and duodenum. The lack of gallbladder filling is due to inflammatory closure of the cystic duct preventing bile backflow into the gallbladder. Evidence of cystic duct obstruction on biliary scintigraphy is highly diagnostic for acute cholecystitis. The sensitivity and specificity for the diagnosis are about 95% each. False positive results can occur in patients in the non-fasting state, those receiving parenteral nutrition, or in the setting of gallbladder stasis. Recent narcotic use or alcoholism. Filling of the gallbladder and common bile duct with delayed or absent filling of the duodenum indicates an obstruction at the ampulla. Biliary leaks as a complication of surgery of the gallbladder or the biliary tree can be confirmed and frequently localized by biliary scintigraphy. HIDA scanning with evaluation of the gallbladder ejection fraction with or without CCK provocation may also be helpful in diagnosing chronic biliary dyskinesia in patients with atypical symptoms. While an ejection fraction of less than 35% is considered abnormal, the exact interpretations and clinical implications of this finding remain a matter of some debate. Magnetic resonance imaging. Available since the mid-1990s, MRI provides anatomic details of the liver, gallbladder, and pancreas similar to those obtained from CT. Many MRI techniques can generate high-resolution anatomic images of the biliary tree and the pancreatic duct. MRI with magnetic resonance cholangiopancreatography offers a focused, non-invasive test for the diagnosis of biliary tract and pancreatic disease. It has a sensitivity and specificity of, and respectively, for detecting cholelithiasis. In many centers, MRCP is the preferred imaging modality for precise evaluation of biliary and pancreatic duct pathology, reserving endoscopic retrograde cholangiopancreatography for therapeutic purposes only. Figure 32-9, magnetic resonance cholangiopancreatography. This view shows the course of the extrahepatic bile ducts and the pancreatic duct. Endoscopic retrograde cholangiopancreatography. While the use of endoscopic retrograde cholangiopancreatography in biliary disease is particularly valuable for its therapeutic capabilities, its diagnostic role should not be overlooked. Using a side-viewing endoscope, the common bile duct can be cannulated through the ampulla of Vater in a cholangiogram performed using fluoroscopy. The procedure requires at least intravenous sedation and in some cases general anesthesia. The advantages of ERCP include direct visualization of the ampullary region and direct access to the distal common bile duct for cholangiography or choledocoscopy. The test is rarely needed for uncomplicated gallstone disease. However, for cases of cholelithiasis, obstructive jaundice, biliary strictures, or cholangitis, ERCP has the advantage of being both diagnostic and therapeutic. If ductal stones are identified on the endoscopic cholangiogram, biliary sphincterotomy and stone extraction can be performed, clearing the common bile duct of stones. If another etiology such as a biliary stricture is found, diagnostic brushings can be obtained at the time of the procedure. In the hands of experts, the success rate of common bile duct cannulation and cholangiography is greater than 90%. Notable complications of diagnostic ERCP include pancreatitis, which occurs in approximately 3.5% of patients, as well as rare occurrences of bleeding, perforation, or infection. Endoscopic choledocoscopy. The development of small fiber optic cameras that can be threaded through endoscopes used for endoscopic retrograde cholangiopancreatography has facilitated the development of intraductal endoscopy. By providing direct visualization of the biliary and pancreatic ducts, this technology has been shown to increase the effectiveness of ERCP in the diagnosis of certain biliary diseases. Intraductal endoscopy has been shown to have therapeutic applications that include biliary stone lithotripsy and directed stone extraction in high-risk surgical patients. It can also allow for direct visualization and sampling of concerning lesions in order to evaluate for malignancy. Studies have thus far shown intraductal endoscopy to be safe and effective, though complications such as bile duct perforation, minor bleeding, and cholangitis have, figure 32-11. A view from the cholecystoscope showing cholangiocarcinoma been described. Further refinement of this technology will likely enhance ERCP as a diagnostic and therapeutic tool. Endoscopic ultrasound. Endoscopic ultrasound has improved significantly in recent years and offers additional diagnostic utility to the workup of biliary disease. It requires a specialized 30-degree endoscope with either a radial or linear ultrasound transducer at its tip. The results are operator-dependent and require a skilled endoscopist, but offer non-invasive imaging of the bile ducts and adjacent structures. Endoscopic ultrasound can also be used to identify choledocholithiasis. It is useful for evaluation of the retroduodenal portion of the bile duct, which is difficult to visualize with transabdominal ultrasonography. Although EOS is less sensitive than ERCP for biliary stones, the technique is less invasive as it does not require cannulation of the sphincter of OD. EOS is also of particular value in the evaluation of tumors near or behind the duodenum and their resectability. Using a linear EOS scope that has a biopsy channel, fine needle aspiration of tumors or lymph nodes, therapeutic injections or drainage procedures under direct ultrasonic guidance can be performed. Percutaneous transhepatic cholangiography, in settings in which the biliary tree cannot be accessed endoscopically. Antegrade cholangiography can be performed by accessing the intrahepatic bile ducts percutaneously with a small needle under fluoroscopic guidance. Once the position in a bile duct has been confirmed, a guide wire is inserted and a catheter is passed over the wire. Through the catheter, an antegrade cholangiogram can be obtained and therapeutic interventions such as tissue sampling, biliary drain insertions, or stent placements performed. Percutaneous transhepatic cholangiography can also be performed through previously placed percutaneous biliary drainage tubes if present. PTC has little role in the management of patients with uncomplicated gallstone disease, but can be useful in patients with bile duct strictures or tumors, as it can define the anatomy of the biliary tree proximal to the affected segment. As with any invasive procedure, there are potential risks. For PTC, these are mainly bleeding, cholangitis, bile leak, and other catheter-related problems. Gallstone disease, prevalence and incidence. Gallstone disease is one of the most common afflictions of the digestive tract. Autopsy reports show that gallstones are present in between 10% and 15% of adults. The prevalence of gallstones is related to many factors, including diet, age, gender, BMI, and ethnic background, with increased prevalence in patients of Native American and Latin American descent. Certain conditions also predispose to the development of gallstones, including pregnancy, non-HDL, hyperlipidemia, Crohn's disease, and certain blood disorders such as hereditary spherocytosis, sickle cell disease, and thalassemia. Surgeries that alter the normal neural or hormonal regulation of the biliary tree, including terminal ileal resection and gastric or duodenal surgery, increase the risk of cholelithiasis. Rapid weight loss following bariatric surgery or lifestyle changes can also precipitate gallstone formation by creating an imbalance in bile composition. Medications such as somatostatin analogs and estrogen-containing oral contraceptives are also associated with an increased risk of developing gallstones. Women are 3 times more likely to develop gallstones than men, and first-degree relatives of clinical treatment, non-surgical management of gallstone disease using medications or lithotripsy has had disappointing long-term results. These modalities are not considered to be part of the primary treatment algorithm for gallstone disease. Surgical cholecystectomy offers the best long-term results for patients with symptomatic gallstones. About 90% of patients with typical biliary symptoms and stones are rendered symptom-free after cholecystectomy. For patients with atypical symptoms such as dyspepsia, flatulence, belching, bloating, and dietary fat intolerance, the results are not as favorable. The laparoscopic approach has been proven to be safe and effective and has become the standard of care for symptomatic gallstone disease, replacing open cholecystectomy in routine cases. 3. Due to the possibility of developing complications related to gallstone disease, patients with symptomatic cholelithiasis should be offered elective cholecystectomy. While waiting for surgery, or if surgery has to be postponed, the patient should be advised to avoid dietary fats and large meals. Diabetic patients with symptomatic gallstones should be encouraged to have a cholecystectomy promptly, as they are more prone to developing severe acute cholecystitis. Pregnant women with symptomatic gallstones who cannot be managed expectantly with diet modifications can safely undergo laparoscopic cholecystectomy. The operation should be performed during the second trimester if possible. Acute cholecystitis. Acute cholecystitis, or infection of the gallbladder, is associated with gallstones in 90% to 95% of cases. Rarely, a calculous cholecystitis can occur, usually in patients with other acute systemic diseases. Obstruction of the cystic duct by a gallstone is the initiating event that leads to gallbladder distension, inflammation, and edema of the gallbladder wall. In less than 1% of acute cholecystitis, the cause is a tumor obstructing the cystic duct. Why inflammation develops only occasionally with cystic duct obstruction is unknown, but it is probably related to the duration of obstruction. Initially, acute cholecystitis is an inflammatory process, probably mediated by the mucosal toxin lysolecithin, a product of lecithin, as well as bile salts and platelet activating factor. An increase in prostaglandin synthesis amplifies the inflammatory response. In acute cholecystitis, the gallbladder wall becomes grossly thickened and reddish with subserosal hemorrhages. Pericholecystic fluid often is present. The mucosa may show hyperemia and adjacent organs. However, free perforation with peritonitis, intrahepatic perforation with intrahepatic abscesses, and perforation into adjacent organs with cholecystoenteric fistula have been described. When gas-forming organisms are part of the secondary bacterial infection, gas may be seen in the gallbladder lumen and in the wall of the gallbladder on abdominal radiographs and CT scans, an entity called emphysematous cholecystitis. Clinical manifestations: about 80% of patients with acute cholecystitis give a history compatible with chronic cholecystitis. Acute cholecystitis often begins as an attack of biliary colic with relapsing and remitting pain in the right upper quadrant or epigastrium that may radiate to the right back or interscapular area. In contrast to biliary colic, the pain of acute cholecystitis does not subside. It is unremitting, may persist for several days, and is usually more severe than the pain associated with uncomplicated gallstone disease. The patient is often febrile, complains of anorexia, nausea, and vomiting, and may be reluctant to move as the inflammatory process creates focal peritonitis. On physical examination, tenderness and guarding are usually present in the right upper quadrant. A mass, the gallbladder, and adherent omentum is occasionally palpable, however. Guarding may prevent identification of this. Murphy's sign, an inspiratory arrest with deep palpation in the right subcostal area, is characteristic of acute cholecystitis. Laboratory evaluation commonly reveals a mild to moderate leukocytosis. However, a normal WBC does not rule out the diagnosis. An unusually high WBC count suggests a complicated form of cholecystitis, such as gangrenous cholecystitis, perforation, or associated cholangitis. In uncomplicated acute cholecystitis, serum liver chemistries are usually normal, but a mild elevation of serum bilirubin may be present along with mild elevation of alkaline phosphatase, transaminases, and amylase. Severe jaundice is suggestive of obstruction of the bile ducts. This can be a result of common bile duct stones or severe pericholecystic inflammation secondary to impaction of a stone in the infundibulum of the gallbladder. That mechanically obstructs the bile duct, known as Mirizzi's syndrome. In elderly patients and in those with diabetes mellitus, acute cholecystitis may have a subtle. Figure 32-16, Mirizzi's syndrome. In uncomplicated acute cholecystitis, serum liver chemistries are usually normal, but a mild elevation of serum bilirubin may be present along with mild elevation of alkaline phosphatase, transaminases, and amylase. Severe jaundice is suggestive of obstruction of the bile ducts. This can be a result of common bile duct stones or severe pericholecystic inflammation secondary to impaction of a stone in the infundibulum of the gallbladder. That mechanically obstructs the bile duct, known as Mirizzi's syndrome. In elderly patients and in those presentation resulting in a delay in diagnosis. These patients may also have higher rates of treatment-related morbidity compared to younger and healthier patients. The differential diagnosis for acute cholecystitis includes, but is not limited to, peptic ulcer disease, pancreatitis, appendicitis, hepatitis, perihepatitis, myocardial ischemia, pneumonia, pleuritis, and herpes zoster involving the intercostal nerve. Diagnosis ultrasonography is considered the most useful initial radiologic test for diagnosing acute cholecystitis with a sensitivity and specificity of 70% to 90%. Ultrasound is effective at documenting the presence or absence of stones, and it can show gallbladder wall thickening and pericholecystic fluid, both of which are highly suggestive of acute cholecystitis. Focal tenderness over the gallbladder when compressed by the sonographic probe also supports the diagnosis of acute cholecystitis. Biliary scintigraphy may be of help in atypical cases if the diagnosis remains in question after initial workup. Lack of filling of the gallbladder after hours indicates an obstructed cystic duct and, in the clinical setting of suspected acute cholecystitis, confirms the diagnosis with a reported sensitivity above. Conversely, a normal HIDA scan with clear filling of the gallbladder rules out the diagnosis of acute cholecystitis. CT scans are frequently performed on patients with acute abdominal pain of unknown etiology, as they can evaluate for a number of potential pathologic processes at once. In patients with acute cholecystitis, a CT scan can demonstrate thickening of the gallbladder wall, pericholecystic fluid, and the presence of gallstones, but it is somewhat less sensitive than ultrasonography. Treatment patients who present with acute cholecystitis should receive IV fluids, broad-spectrum antibiotics, and analgesia. The antibiotics should cover gram-negative enteric organisms as well as anaerobes. Although the inflammation in acute cholecystitis may be sterile in some patients, it is difficult to know who is secondarily infected. Therefore, antibiotics have become a standard part of the initial management of acute cholecystitis in most centers. Cholecystectomy is the definitive treatment for acute cholecystitis. In the past, the timing of cholecystectomy has been a matter of debate. Early cholecystectomy performed within 72 hours of the onset of the illness is preferred over delayed cholecystectomy that is performed 6 to 10 weeks after initial medical treatment and recuperation. Several studies have shown that unless the patient is unfit for surgery, early cholecystectomy should be recommended as soon as possible, as it offers the patient a definitive solution in one hospital admission, quicker recovery times, similar complication rates, and an earlier return to work. Laparoscopic cholecystectomy is the procedure of choice for acute cholecystitis. The conversion rate to an open cholecystectomy has fallen in recent years to less than 5% as laparoscopic equipment and experience has improved. While laparoscopic cholecystectomy for acute cholecystitis may be more tedious and take longer than an elective cholecystectomy for symptomatic cholelithiasis, the laparoscopic approach remains safe and effective. Even in the setting of acute and sometimes severe inflammation, open cholecystectomy must remain an option in particularly difficult cases or in patients suspected of having prohibitive intra-abdominal adhesions, but it is rarely the primary treatment choice. When patients are medically unfit for surgery due to the severity of their illness or medical comorbidities, they can be treated with antibiotics and biliary decompression with cholecystostomy tube placement, which is usually effective in stabilizing the patient. For those who do recover after cholecystostomy, the tube can be removed once the tract is mature, and cholangiography through it shows a patent cystic duct. Elective laparoscopic cholecystectomy can be scheduled within approximately 2 weeks, assuming their medical fitness recovers. Failure to improve after cholecystostomy may be due to gangrene of the gallbladder or perforation, in which case damage control surgery may be unavoidable. Cholelithiasis, Common bile duct stones may be small or large, single or multiple, and are found in 6% to 12% of patients with stones in the gallbladder. The incidence increases with age. About 20% to 25% of patients above the age of 60 with symptomatic gallstones have stones in the common bile duct as well as in the gallbladder. The vast majority of ductal stones in Western countries are formed within the gallbladder and migrate down the cystic duct into the common bile duct. These are classified as secondary CBD stones, in contrast to the primary CBD stones that form in the bile duct itself. Secondary stones are usually cholesterol stones, whereas primary stones are usually of the brown pigment type. The primary stones are associated with biliary stasis and infection, and they are more commonly seen in Asian populations. Biliary stasis, leading to the development of primary CBD stones, can be caused by biliary strictures. Cholangitis is one of the main complications of cholitical stones. Acute cholangitis is an ascending bacterial infection associated with partial or complete obstruction of the bile ducts. Hepatic bile is sterile, and bile in the bile ducts is kept sterile by continuous antegrade bile flow and by the presence of antibacterial substances in bile, such as immunoglobulin. Mechanical hindrance to bile flow facilitates ascending bacterial contamination from the bowel. Positive bile cultures are common in the presence of bile duct stones, as well as with other causes of obstruction. Biliary bacterial contamination alone does not lead to clinical cholangitis. The combination of both significant bacterial contamination and biliary obstruction is required for its development. Gallstones are the most common cause of obstruction in cholangitis. Other causes include primary sclerosing cholangitis, benign and malignant strictures, parasites, instrumentation of the ducts, and indwelling stents, as well as partially obstructed biliary enteric anastomosis. The most common organisms cultured from bile in patients with cholangitis include E. coli, Klebsiella pneumoniae, Streptococcus faecalis, Enterobacter, and Bacteroides fragilis. Clinical manifestations cholangitis may present as anything from a mild, self-limited episode to a fulminant, potentially life-threatening septicemia. Patients with gallstone-induced cholangitis are most commonly older and female. The most common presentation is fever, epigastric or right upper quadrant pain, and jaundice. These classic symptoms, known as Charcot's triad, are present in about 2/3 of patients. The illness can progress rapidly with the development of shock and altered mental status, known as Reynolds' pentad. However, the presentation may be atypical, with little, if any, fever, jaundice, or pain. This occurs most commonly in the elderly, who may have unremarkable symptoms until the process is already quite advanced. Patients with indwelling stents are at particularly high risk for cholangitis, though rarely become jaundiced, as a patent stent will prevent the obstruction of bile flow. On abdominal examination, the findings are indistinguishable from those of acute cholecystitis. Diagnosis: leukocytosis, hyperbilirubinemia, and elevation of alkaline phosphatase and transaminases are common and, when present, support the clinical diagnosis of cholangitis. Ultrasonography is helpful as it will document the presence of gallbladder stones, demonstrate dilated ducts, and possibly pinpoint a site of obstruction. CT scanning and MRI can show pancreatic and periampullary masses if present, in addition to the ductal dilatation. However, abdominal imaging will rarely elucidate the exact cause of cholangitis, and the initial diagnosis is generally made clinically. Treatment. The initial treatment of patients with cholangitis includes broad-spectrum IV antibiotics to cover enteric organisms and anaerobes, fluid resuscitation, and rapid biliary. Laparoscopic cholecystectomy. The patient is typically positioned supine, with the operating surgeon standing at the patient's left side. Split leg positioning with the surgeon standing between the patient's legs can also provide ergonomic access to the right upper quadrant. Tucking one arm can be helpful if a cholangiogram is planned to allow easier maneuvering of the fluoroscopy machine around the patient. Pneumoperitoneum is established with carbon dioxide gas, either with an open technique, optical viewing trocar, or closed needle technique. Typical access is at the supraumbilical region, though in the case of previous surgery or scars, alternate access sites should be considered. Once an adequate pneumoperitoneum is established, a or MM trocar is inserted through the supraumbilical incision, through which a or MM laparoscope is introduced. Traditionally, 3 additional ports are then placed with a 10 or 12 mm port in the epigastrium, a 5 mm port in the right mid-clavicular line, and a 5 mm port in the right flank. Additional ports may be placed as needed to aid with retraction in difficult cases through the lateral most port. The assistant uses a locking instrument to grasp the gallbladder fundus and retract it over the liver edge and upward towards the patient's right shoulder. This will help visualize the body of the gallbladder and the hilar area, Exposure may be facilitated by placing the patient in reverse Trendelenburg position with slight tilting of the table to bring the right side up. Through the midclavicular port, the surgeon uses a grasper in the left hand to retract the gallbladder infundibulum laterally and expose the neck of the gallbladder and hepatoduodenal ligament. It may be necessary to take down any adhesions between the omentum, duodenum, or colon to the gallbladder in order to reach the infundibulum. The majority of the dissection can then be performed with the right hand through the epigastric port, utilizing a combination of electrocautery and sharp and blunt dissection. Dissection starts at the infundibulum of the gallbladder, just above the takeoff of the cystic duct. The peritoneum, fat, and loose areolar tissue around the gallbladder and the cystic duct. Gallbladder junction is dissected off and reflected inferiorly toward the bile duct. This is continued until the gallbladder neck and the proximal cystic duct are clearly identified. The next step is the identification of the cystic artery, which usually runs parallel to and somewhat behind the cystic duct, and often lies behind a prominent lymph node. At this point, a critical view of safety should be obtained. This requires that the hepatocystic triangle is cleared of fat and fibrous tissue. The lower third of the gallbladder is separated from the liver to expose the cystic plate, and two and only two structures are going into the gallbladder. At this point, an intraoperative cholangiogram can be performed if indicated. With a critical view of safety obtained, the cystic duct and artery are clipped with two clips at the base and one clip on the gallbladder side. They can then be safely divided. Sometimes a very dilated cystic duct may be too large for clips. Such ducts can be successfully managed by ligation with an endoloop, laparoscopic stapler, or suture closure. Finally, the gallbladder is dissected off the liver bed using electrocautery while watching for potential abnormal posterior branches of ducts or arteries. Before the gallbladder is completely removed from the liver edge, it can be used as a retractor for a final evaluation. A calculous cholecystitis is an acute inflammation of the gallbladder that occurs in the absence of gallstones. It is a rare entity that typically develops in critically ill patients in the intensive care unit. Patients on parenteral nutrition with extensive burns, sepsis, major operations, multiple trauma, or prolonged illness with multiple organ system failure are at risk for developing a calculous cholecystitis. The cause is unknown, but gallbladder distension, bile stasis, and ischemia have been implicated as causative factors. After resection, pathologic examination of the gallbladder wall after an episode of a calculous cholecystitis reveals edema of the serosa and muscular layers, with patchy thrombosis of arterioles and venules. The ability to recognize the symptoms and signs of a calculous cholecystitis can depend on the condition and mental status of the patient. But a calculous cholecystitis can be similar to acute calculous cholecystitis, with right upper quadrant pain and tenderness, fever, and leukocytosis. In the sedated or unconscious patient, the clinical features are often masked, but fever and elevated WBC count, as well as elevation of alkaline phosphatase and bilirubin, are indications for chojejunostomy, further investigation. Ultrasonography is usually the diagnostic test of choice, as it can be done bedside in the intensive care unit. It can demonstrate the distended gallbladder with thickened wall, biliary sludge, pericholecystic fluid, and the presence or absence of abscess formation. CT scanning can aid in the diagnosis of a calculous cholecystitis and additionally allows a more general evaluation of the abdomen and chest to rule out other sources of infection. A HEDA scan can also be useful if it shows non-visualization of the gallbladder, but it is less sensitive and can have higher false positive rates in patients who are in a prolonged fasting state on total parenteral nutrition or have liver disease. Once the diagnosis is confirmed, a calculous cholecystitis requires urgent intervention as rapid deterioration can occur. This should include early broad-spectrum antibiotics and fluid resuscitation. If the patient is stable to undergo an abdominal operation, laparoscopic cholecystectomy is the most definitive treatment, and it can be safely performed even in the setting of severe acute inflammation. However, if patients are critically ill and unfit for surgery, percutaneous cholecystostomy is the best treatment choice. About a patients will improve with a percutaneous cholecystostomy tube. Interval cholecystectomy can be discussed with the patient after they have recovered from their acute illness, but it is not strictly required in the absence of gallstone or other identified gallbladder pathology. Choledical cysts. Choledical cysts are congenital cystic dilatations of the extrahepatic and or intrahepatic biliary tree. They are rare, with an incidence of between 100,000 and 150,000 in populations of Western countries, but are more common in populations of Eastern countries, occurring in as many as 1,000 individuals. Choledical cysts affect females 3 to 8 times more often than males. Although frequently found in infancy or childhood, nearly 1/2 are diagnosed in adults. The cause is unknown, but it is believed that weakness of the bile duct wall and increased pressure secondary to partial biliary obstruction can contribute to biliary cyst formation. More than 90% of patients have an anomalous pancreaticobiliary duct junction, with the pancreatic duct joining the common bile duct outside the duodenal wall, creating a long common channel. This may allow free reflux of pancreatic secretions into the biliary tract, leading to inflammatory changes, increased biliary pressure, and cyst formation. The cysts are lined with cuboidal epithelium and can vary in size from small dilations to giant cystic masses. The typical clinical triad of biliary cysts includes abdominal pain, jaundice, and a palpable mass, though this constellation is seen in less than 1/2 of patients. Adults may present with cholangitis. Blood tests will often be normal, though elevations of transaminases can be seen in cases of infection or obstruction. Ultrasonography or CT scanning will confirm the diagnosis, but ERCP or MRCP are essential to formally assess the biliary anatomy and to plan the appropriate surgical treatment. The risk of cholangiocarcinoma in patients with choledochal cysts is 20 to 30-fold higher than in the general population and varies with the patient's age and type of cyst. For this reason, excision is recommended whenever possible when high-risk choledochal cysts are diagnosed. Choledochal cysts are classified into 5 types, depending on the location and structure of the cysts. The subcategories of choledochal cysts are defined in Fig. Type 1 cysts are the most common form, accounting for approximately of cases and have the highest risk of malignancy. For types 1 and 2, excision of the cystic dilations in the extrahepatic biliary tree, including cholecystectomy, with either simple cyst excision or duct resection with Roux-en-Y hepatico-jejunostomy is ideal. Type 3 cysts create a treatment challenge as full resection would require pancreaticoduodenectomy. Given that type 3 cysts are associated with the lowest malignancy risk of any choledochal cyst, sphincterotomy and surveillance is generally recommended over formal excision. In type 4, excision of all cystic tissue and reconstruction is again recommended. For type IVA, which is characterized by multiple cysts with intrahepatic involvement, additional segmental resection of the liver may be required if intrahepatic stones, strictures, or abscesses are present. Type V, colical cysts are very. The pancreas is perhaps the most unforgiving organ in
Hi, I'm Jeff Klein, editor of Radiographics, and today I am pleased to have with us Dr. Argo.
The pancreas is a retroperitoneal organ that lies in an oblique position, sloping upward from the C. One incomplete fusion of the dorsal and ventral pancreatic ducts results in pancreas divisum, but a variety of ductal anomalies can be seen. Magnetic resonance cholangiopancreatography as well as endoscopic retrograde cholangiopancreatography can identify these ductal anomalies. And clarification of the ductal pattern of the pancreas is important before attempts at interventions.